move on to the endocrine system. This one was a very difficult one for me when I was first starting off in EMS. Because like I say, the understanding of the human body it's almost like a jigsaw puzzle, all right? If you think of medicine as a jigsaw puzzle, as EMTs, our whole job is just to find like the edge pieces of that jigsaw puzzle, just so we get an idea of the scope of that puzzle. As paramedics, we started to fill in a lot of that puzzle, right? We're starting to figure out which colors go where, and we're starting to get them in the right areas, right? Again, I'm going to use this analogy of a jigsaw puzzle a lot, so bear with me. We're separating them by color or whatever in order to try to figure out where things will go. So we have a general idea. If you guys continue to specialize, you'll fill in more of that jigsaw puzzle. It'll never be possible for anyone to fully complete it because medicine is a very big jigsaw puzzle. All right. In fact, even just getting all the edge pieces would be a very huge endeavor. I don't even think I'm there yet. But that's the goal, right? Is to start to understand. Once you see the edge pieces, you'll be able to fit things in more easily, and this whole system is going to make a lot more sense. So again, what is the endocrine system? The endocrine system, as its name implies, endo, within, as opposed to an exocrine system. Remember, those are the sweat glands, your ureters, your breathing, your mammary glands, all of those things which offload toxins in the body, which are electrolyte imbalances or the byproducts of energy, out of the body because we don't want them in there. That's not what they're good for. So what the most important part of this endocrine system is probably the pituitary gland and the hypothalamus. But what do those things do? Well, they work together. The pituitary gland releases a bunch of hormones, but it only releases them because the hypothalamus interprets messages from the brain via the thalamus and then stimulates the pituitary gland to release its chemicals. Then we have two pituitary glands. They hang in your brain almost like a ball sack, really. And I hate to use that analogy, but that's kind of what it looks like, all right? It's literally two sacks hanging down in there and glands in your brain. Now, they're not like dangling in your brain, swaying back and forth as you walk, but they are up in there, part of the diencephalon, all right? So the anterior pituitary releases quite a few hormones. A lot of them are going to be directly related to our maintenance of our blood pressure and sympathetic and parasympathetic nervous systems. A lot of them are also related to sex, because remember, biology says that we need to pass on our genetic material. That's really the most important things. We are essentially cannons, right? We are just made to shoot off our genetic material in as many directions as possible in the hope that some of it sticks. And everything we do is kind of in service of that. So we have thyroid stimulating hormone. This stimulates the thyroid, which we'll talk about in a second. Adrenal corticotropic, the adrenal cortex hormones. Remember, the adrenal glands sit on top of your kidneys. The adrenal medullas, the inside portion of the adrenal glands, are actually part of the CNS, remember? Follicle stimulating hormones and luteinizing hormones, these ones are sex hormones. They help us secrete estrogen or sperm production, and luteinizing hormone, ovum and estrogen. In males, it stimulates the release of testosterone. Women also have testosterone, and men also have estrogen. Most of that is released from the adrenal glands or from other sections of the brain. Women just have much lower doses of testosterone, and men have much lower doses of estrogen. However, that can change pretty rapidly depending on, slight chemical abnormalities from one person to the next. You can generally tell, we can test these levels if anyone's ever curious. Other chemicals are the melanocyte stimulating hormone. This stimulates the synthesis of melanin. This is what gives skin its pigmentation. What's really interesting is that there is zero difference. We have this concept of different races, right? That's not a thing. Other than melanin production in our skin, there is no genetic difference between the races, okay? The differences that we note are because of cultural adaptations and locational adaptations that happened over time. All right. And it takes a while for this, but not as long as you might expect. In fact, if very white people move to an area with a lot of sun and it's necessary for them to suddenly have more active melanin to protect us from overexposure to the sun, it'll take about 2,000 to 3,000 years for those people to get darker and darker and darker. This is why we have different colors skin from people hailing from different portions of the world. It made a lot more sense when it was very unlikely that we would travel. Now it's very easy. I can hop on a plane and in 18 hours, I can be on the other side of the world. Well, I mean, theoretically speaking, of course. But that used to not be the case. So what's really interesting is there is really no genetic difference from one race to the other. All the differences that we can note, physically wise, come about from locational differences and genetic predispositions. Other than that, no difference between the races. Also, we will release growth hormone, which stimulates growth in all organs. And finally, prolactin, which is breast development and pregnancy and lactation. Men also release small amounts of prolactin. It does not help with these things, obviously. The posterior pituitary only releases two chemicals. ADH, antidiuretic hormone, which you guys remember, diuretics are medicines that cause us to lose water, aka to give up water from our kidneys. The nephrons, you will remember, are the functional unit of the kidneys, and water full of electrolytes goes up and down these tubules, and then the tubules will pull in certain electrolytes they want to keep, and they'll put in electrolytes they want to get rid of, and they will use water to facilitate that movement. Finally, they'll try to draw as much of that water out as they can so you can just pee out the rest. Antidiuretic hormone causes the retention of water in the kidneys. So it'll pull water out of those tubules to store it, just in case pressure is about to get low. And the other one is oxytocin. Stimulates uterine contraction and the release of milk into the milk ducts. But that's not all oxytocin does. Our understanding of oxytocin is that it also plays a role in long-term relationships and development of those things. Falling in love is believed to be an oxytocin-induced reaction. The same way that a lot of women will describe this kind of this feeling of euphoria after giving birth because of the release of all this oxytocin. There's also a lot of debate about other chemicals that are released during childbirth. It's a very specialized process. It makes sense that a bunch of very pleasant chemicals would get released for childbirth because childbirth in and of itself is not a pleasant experience, and we need to have some sort of incentive to do it. This is why we can't really explain why we love babies, but we do. We can't really explain why a baby's cry can be heard by everyone in the nearby vicinity. But again, these are biological responses. It makes sense for us to respond to a child crying because that's a sound that needs to get us going. Here's an interesting note. If you have a female in premature labor, you can try giving her a fluid bolus. What will this do? It's going to interact with the ADH, and then hopefully that will also affect the oxytocin being released from the same gland. The hypothalamus manufactures and controls the function of the pituitary glands by releasing hormones, either stimulate or inhibit the anterior pituitary. Remember, that's the one that releases 6 or 7 chemicals. The posterior pituitary is the one that only releases ADH and oxytocin. Going on down the body, although there are some more in the head, the pineal glands, which we'll go back to, there's the thyroid. The thyroid is in the throat underneath things. So we think of the thyroid as being the Adam's apple, which is this layer of cartilage that surrounds it. Sorry, that's the larynx right there. This is the thyroid sits underneath the Adam's apple, and it forms up in there. What does the thyroid do? It basically helps us with calcium in our bones. It'll either cause parathyroid hormone stimulates the breakdown of calcium in the bones. And then on the back, we've got these parathyroid glands that stop it. So sorry, excuse me real quick. Thyroid hormones, calcitonin stops the breakdown of calcium. And then the parathyroid glands in the back cause calcium to be released from the bones. Now, what is important about calcium? Here's what's important about calcium. Calcium is very important for muscle contractions. Let's think about this for a second. Go ahead and feel your bicep unflexed, just straight. It's very soft, right? Now, flex your bicep. It becomes very hard. Why is that? Is it because the muscles are contracting and taking up more space? No, not exactly. It's because of calcium release. So we know that we store calcium in our bones. And this is important, right? Our bones don't just produce red blood cells and give us structure. They also store calcium. Calcium is very important for muscular interaction. So just a quick overview of the muscles. How do they work? There's little tiny things in there called actin and myosin. And basically you can think of them as like little tiny grabber claws, and they're sitting there. Now, outside of these tubules of the muscles, because the muscles are nice, long muscle strands, all right? They're all housed in these kind of tubules called sarcoplasmic reticulum. In that is calcium. Every time we flex a muscle, calcium is released into the muscles, and it allows those actin and myosin to grab onto each other and pull and contract. They're little tiny grabbers. Almost think of it like the legs of a millipede, grabbing and walking up and down. It shortens and lengthens, shortens and lengthens. And it shortens by releasing calcium. Calcium in high concentrations increases hardness. The reason your muscles get hard when you flex them is because calcium is being flooded into them. The second that we unflex our muscles, that calcium is drawn back into the sarcoplasmic reticulum where it's not interacting with things, and the muscles become less hard. So why is this important for the thyroid? Because remember, we have patients that have hypothyroids, underactive thyroid glands. That means that they're going to have usually increases or decreases in the amount of calcium available in their body. Calcium is important for all muscle contractions, including the contractions of the heart. So people with thyroid issues are much more likely to develop atrial fibrillation. Why is that? Well, remember, atrial fibrillation means that the atria are fibrillating, usually due to release and improper release of calcium. What is the drug that most people on AFib are given besides sometimes blood thinners? Calcium channel blockers. Again, it's all because of too much or too little calcium within the system, usually too much calcium. So that's why thyroid issues are very heavily related to AFib. Kind of an interesting note there. The adrenal cortex hormones, mineralocorticoids, aldosterone, glucocortisol, and then androgens. They stimulate the sex drive in females. We think they have little effect in males. Come on, we know that's not true. We don't really understand what it does in males. But does that mean it does nothing? Maybe. Now, here's the thing about this is it might do absolutely nothing in males, and it might only affect females. And the reason males develop it is because, and this is an interesting fact, we were all originally females. For the first 5 to 6 weeks, all fetuses are female. 100%. You and I were both females. Doesn't matter if you're a girl now and I'm a boy now. That's not important. We were all females originally. At that 5 to 6 week mark, if we have received a Y chromosome from our father, we will start the process of masculinization and defeminization. However, all of those chemicals that would have become female chemicals are still within us. So maybe they just still release and they don't do anything, or maybe they do still do something. There's the adrenal cortex sitting on top of the kidneys. Remember, the medulla is in the middle. The cortex is on the outside. The medulla releases epinephrine and norepinephrine. Remember, this is also part of the CNS. This prolongs sympathetic nervous response during stress. Next, and probably most importantly, the pancreas. One of my favorite rides at Disneyland was Pirates of the Pancreas. So the pancreas releases not 2, but actually 3 chemicals. There's actually a third one which is not listed on this site. Glucagon from the alpha cells release, it helps to stimulate liver gluconeogenesis, which is the creation of new glucoses from glycogen. Insulin promotes glucose entry into the cells, causing a decrease in blood glucose. This is created from the beta cells, alpha, beta, but we also have delta cells, and they release somatostatin, which again is just another chemical. It's not going to be important for the testing though. But just know that there are actually 3 chemicals released in the pancreas, not just 2. Pancreas is related right next to the duodenum. The duodenum is the first section of the large intestines after the stomach. Next, let's go down to the sexual organs. The ovaries in male. Now, here's another interesting note, you guys. Like I said, the first 6 weeks we're all female, and then we'll begin that process of masculinization and defeminization. So all of our sexual organs, all of the tissue that makes up our sexual organs are homologous. They have the same embryonic tissue. That's what the word homologous means. Meaning that genetically there's no difference between testicles and ovaries until this process of masculinization and feminization comes in. In fact, all of the structures of genitalia transfer to become something different when we become a male. So obviously the ovaries become the testicles. The fallopian tubes become the vas deferens in males. Does anybody want to guess what the uterus becomes in males? What would the uterus become? Because we obviously don't have a uterus, but we do have something that women do not have. Which internal organ do you think it becomes? The prostate is correct. Yes, the prostate is the vestigial remains of the uterus. Finally, the penis is formed from the vaginal canal and the clitoris. This is penis is a fairly complex structure, just like the vagina and the clitoris are. But these 2 structures can become the same, all right? So that's what's going on in our genitalia. And it's kind of interesting that the main functional difference is internal versus external. Males, it needs to be external. In fact, that's the reason why the testicles hang on the outside and we don't just have them stored up in our abdomen, because realistically, that would make a lot more sense. It does not make sense biologically to have our weakest, most susceptible to injury portion of our body, and by the way, arguably one of the most biologically important functions of us, hanging on the outside in plain view of everything. But it needs to be cooler because sperm will not form at the 98.6 degrees of internal body temperature. It needs to be about 2 degrees cooler or sperm won't form. So that's the reason why that works that way. Now, the ovaries released estrogens and progesterone, and in the testes in male, release testosterone. The thymus. The thymus is where the T cells are matured. Remember, I told you about T cells. They're white blood cells that mature in the thymus. So all white blood cells are created in the bones as stem cells originally. Then they're sent to the thymus to be taught. You can think of it as General Thymus teaching his army how to fight in the thymus. Now, the thymus degrades over time. By the time we're adults, our thymus is pretty much completely deteriorated, and all the T cells have already been trained and they're already circulating in our body. That's where the thymus sits. It sits underneath the sternum. Finally, the placenta, also again part of the endocrine system because it's releasing its chemicals interiorly. Chorionic gonadotropin, estrogen, and progesterone. This one right here, by the way, is what causes morning sickness. Chorionic gonadotropin. There's a picture of a placenta. What's really interesting about the placentas are, you guys maybe have met people that have kept their placentas after giving birth. I've given birth to 5, not given birth, I have delivered 5 babies in my career. And 2 of those mothers asked me to keep their placenta so that they could, I don't know what they wanted to do with it, but they wanted to keep it for something. The reason for this came from a belief because animals will eat their placentas. Like, let's picture a giraffe. Giraffe gives birth. It then bends down, it licks the amniotic fluid off of its baby, and then it eats the placenta. Why do animals do this? Not just giraffes, by the way. A lot of animals do this. Most animals eat their placentas. Why do they do that? Well, because they're friggin' animals, okay? They will eat pretty much anything. And they also live in the wild where, like, jaguars and lions and other things live. And animals, if you guys have ever watched the National Geographic Channel, they love eating babies. They love eating each other's babies because it's the easiest thing to catch, right? It's the easiest meal they can get. Plus, that meat's got to be so tender. It's not necessarily for the nutrients, although that is definitely a part of it. Specifically, Molly, the iron is what they're trying to re-ingest. Iron is vitally important for hemoglobin. Iron is what allows us to offload oxygen from the hemoglobin, which is kind of the whole point, right? Hemoglobin's great. It's great that we can store oxygen on it, but hemoglobin does us zero good if we can't offload the iron from it, which is why we get anemia, which is a low iron content. That's a problem because now we're not going to be perfusing as efficiently. Just as a quick side note, because this is pretty fascinating, iron is not created on the planet Earth. There's tons of iron on Earth, and we're lucky there is because that's the reason that we're alive. But iron is only created in the heart of an exploding star. Remember I told you guys yesterday that you are, in the most literal sense, cosmic? That's true. Every single atom of iron was created through a fusion reaction in the heart of a giant exploding supernova star, which then exploded, shot that iron out into the universe, and then eventually, over millions of years, gravity and the forces of nature conspired to pull it together into a spiral where it formed our sun, our planets, and eventually us. We are a very happy accident. That's why iron's so important. You don't need to eat your placentas, as I guess what the moral of what I'm trying to get at here. We can take, an iron pill or like a gummy vite, or just have like a good steak dinner or something, we'll be able to get that iron back in our system eventually. Pineal hormones. So the pineal glands, again, up in the brains, they release melatonin, which inhibits tropic hormones that affect the ovaries, may be involved in the body's internal clock. Pineal gland is up in the brain. The heart also has endocrine features to it. It releases something called Atrial Natriuretic Hormone, which regulates fluid and electrolyte homeostasis within the heart muscles. What can go wrong with the endocrine system? Well, obviously, quite a bit. Most commonly, what we're going to see are hypo and hyperthyroid, and then all of the problems related to diabetes, which are all of these: hypoglycemia, hyperglycemia, DKA, and then Hhns, which is hyperosmolar hyperglycemic non-ketotic syndrome or non-ketotic condition. We're also going to go over some of these guys too, which we'll cover when we get to them. So diabetes mellitus. Remember, there's also another one called diabetes insipidus, although that's extremely rare and we probably will not run into it. Diabetes mellitus is a condition in which the patient experiences chronically elevated blood glucose levels. It's the most common endocrine disorder, affecting 60% of the population. Type 2, most common, makes up 90 to 95% of all cases. Type 1 is a chronic autoimmune process that destroys the beta cells in the pancreas. Remember, the beta cells produce insulin. Unknown cause, but could be genetics, environment, or viral infections. So, real quickly, before we get too much further into diabetes, I want to talk a little bit about how diabetes affects the body. And it's kind of interesting. So maybe you guys remember learning about a couple of things that are typical presentations for diabetes patients are the three polys: polyphagia, polydipsia, polyuria. Polyphagia means eating a lot of food. Polydipsia means drinking a lot of water or chronic thirst. And then polyuria is peeing a bunch and a bunch and a bunch. Why do we react this way to very high levels of sugar in our body? Well, it's a twofold answer. It's because your cells of your body receive sugar or they don't receive sugar, and then they send impulses to your brain. They send a little message to your brain saying, hey, I have sugar, too much sugar, or I don't have enough sugar. Your vasculature is pumping that sugar around, and it's also sending messages to your brain saying, I need more sugar, or I have way too much sugar. The problem comes because the cells of your body and your vasculature can't communicate to each other. And your brain is getting two different messages at the same time. And instead of figuring out the true problem, it's just saying, okay, let me help both of you, even though helping one is actually hurting the other. So here's what happens. The cells of your body are not getting any sugar, okay? All that sugar is staying in the vasculature because there's no insulin to allow it to enter into the cell. It's very big. Even though they're very simple sugars, they're still too big to enter into the cells without help. So the cells aren't getting any sugar. So they send a message to your brain saying, hey, can you please make this guy eat or something? I don't know what's going wrong, but I'm not getting any sugar. And your brain says, oh yeah, no problem. Let me make him real hungry. So your brain's making you hungry. So you're eating more food, increasing your sugar levels. At the same time, your vasculature is full of sugar, right? Very high levels of sugar. It's bad for it. So your vasculature says to your brain, hey, I've got way too much sugar. We need to get rid of some of this. I guess the cells are fully fed. They don't need any more of this. So you can get rid of it. So your brain says, okay, let me go ahead and pee all that out for you. And while I'm at it, I'm going to go ahead and make you drink some more water just so you can continue to pee. So you're peeing frequently. You're so thirsty and you're eating. You're hungry because your cells are hungry, even though your blood is too sugary. So that's what's going on. And that's why we get these kind of missed signal messages from diabetes. This is why it can be such a damaging disease. Also, because that sugar is very damaging to you. It's not only damaging to your vasculature, and it'll cause arteriosclerosis much quicker, but it also is damaging to your kidneys because all of that utilization of your kidneys is damaging. Passing that much sugar through your kidneys is hard on them. And you're also at a higher risk of becoming dehydrated because you're peeing so much and your body's trying to flood fluid into your vasculature to dilute that sugar. Type 1 diabetics are rare, okay? They're born with an autoimmune disease that's attacking their beta cells. Usually they'll just get discovered at about 10 to 14 years of age because they'll go into DKA. Again, polyuria, polydipsia, polyphagia. I just explained why that happens. They're going to have to take supplemental insulin. In fact, normally type 1 diabetes is called insulin-dependent diabetes, or it can be called that. They're prone to low blood sugar and DKA. All of us can get our blood sugar low, and for us, we start to get cranky, right? If we don't eat food and we get hungry and our blood sugar starts getting low, sometimes we'll just become a little bit unpleasant. We'll just start getting cranky, we start getting less patient with things, more frustrated. I'm sure you guys have experienced that before. We have to take we have to get some sugars in there to feel better. But if you're type 1 diabetic and you're taking insulin, you're going to get insulin in different sorts of dosages. Rather than getting a steady supply of insulin all day long, you're going to be getting big doses of insulin all at once, which can put us hypoglycemic very quick. Remember, the brain needs glucose. It can't use any other sugars to function. So if our glucose levels get low, the brain is going to start getting altered. Type 2 diabetics, their pancreas is still secreting insulin. Blood glucose is going to remain elevated in spite of this, though. It's not enough insulin for the amount of sugar in the blood or the amount of carbohydrates in the blood. Remember, all sugars are carbohydrates. So diabetes is technically a carbohydrate intolerance, not necessarily a sugar intolerance. And that's a common misnomer. A lot of people used to think that a high sugar diets would cause diabetes. And let me tell you that a high sugar diet is not good for you, and it can cause diabetes, but much more likely to cause diabetes are processed meats. Processed meats are extremely damaging to you, and you should be very careful if you eat them on a regular basis. I know. Why does it have to be all the good stuff that's bad for us? Type 2 diabetics will usually start up in middle age. obese body mass, more gradual onset of symptoms, and sometimes, frequently, it's reversible. Low sugar, usually one common in type 1 diabetics, usually because they gave themselves an insulin shot while they were cooking and then they did not eat in time, or they forgot to eat, or there was a delay. It happens all the time at restaurants or at the home. The problem is they start cooking food, they take their insulin shot, they get altered, they sit down, their food's still cooking, and now it causes fires. That's happened to me, or not happened to me, but it's called that I've been on multiple times. Too much insulin or not enough glucose, missing a meal, a couple things can cause this. Alcohol will inhibit gluconeogenesis and glycogenolysis. Remember, glycogenolysis is the breaking up of glycogen, fatty deposits around your liver, and then it goes through a process called gluconeogenesis where it turns those into new sugars. Alcohol affects that. So diabetics need to be very careful. Type 1 diabetics need to be very careful about their alcohol intake. Most diabetes mellitus patients begin to exhibit symptoms when their sugar drops below between 50 and 60. Normally, I'd say under 60, you should be concerned. Expect them to be altered. Also depends on how quickly the blood glucose falls. Hyperadrenergic, which is associated with an increase in circulating epinephrine from sympathetic nervous system stimulation. And then neuroglycopenic, dysfunction of brain cells due to glucose deprivation. This is what's happening in hypoglycemia. Essentially, we're altered. Altered LOC, sweating, agitation, seizures. Always perform blood glucose check prior to administration of oral glucose or D50, especially if they're altered. Obviously, just because someone's altered doesn't mean we start giving them sugar. We need to check their sugar levels. If it's below 60, high index of suspicion that they're altered. Most diabetics I've seen that are experiencing hypoglycemic conditions are going to be probably in the 30s, 40s. I've never really seen anyone lower than the 30s in their glucose levels. I have noticed something interesting in that a lot of diabetics have this weird desire to straighten out their joints, like their elbows and their arms and stuff like that. And they kind of need to like walk with their elbows straightened out. It's something that I've noticed. And then when I talk to people afterwards, you know, after you give them the D50 and they wake up and they become normal people again, they'll start talking. And a lot of them have said, yeah, they feel this weird compulsion to straighten out their elbows. So that's something interesting that I've noticed throughout my assessments. I haven't been able to find very much information on that, though. I don't know if it's just a coincidence I've seen it in a couple patients or if there's something actually going on there. Finally, not finally, but next, hyperglycemia, which is high blood sugar. Now we're expecting anything technically over 150 or over 120. I'm not sure exactly where the cutoff is technically considered hyperglycemia, although I'm not realistically concerned until we start seeing about over 300 or so. This can become two different things: DKA, diabetic ketoacidosis, and Hhns, hyperglycemic hyperosmolar non-ketotic syndrome. We tend to use DKA as a catch-all for someone whose sugar level is very high, but realistically, most DKA patients are type 1 diabetics. Most Hhns patients are type 2 diabetics, although both of them can present either way, and both of them can happen to people with no diabetes at all. So what's the difference between these two? Well, DKA, again, most often in type 1, usually associated with some stressor of the body, trauma, infection, heart attack, stroke. Does occur, but with less frequency in type 2. But 25% of them happen to people with no history of diabetes at all. Expect them to have a blood sugar of about 300 to 600. The cells are starved for glucose, but the brain receives enough glucose to prevent them being altered. This is why they're not going to act any differently, because the blood-brain barrier does not require insulin for glucose diffusion. Therefore, the patient does not experience the onset of mental status changes. Excuse me. 3 major pathophysiologic symptoms associated with DKA are metabolic acidosis, again, because the name's right in there, diabetic ketoacidosis. This is too much acid buildup in our body. Osmotic diuresis, meaning that water is also being lost in order to facilitate the movement of all of this sugar. And then electrolyte disturbances. Maybe you guys are familiar with the keto diet. That's one that gained a lot of popularity. It seems to work pretty well for a lot of people. What happens when you're enter a keto diet? You stop your intake of carbohydrates. So you're not really eating any sugars. You're not eating any breads or pastas or things like that. So what does the body do? The body, in need of sugars, starts breaking down your fat tissue. It'll start breaking down your muscle tissue if you're not careful, but it'll break down your glycogen stores and then your fat tissue in order to provide itself with sugar. How does this affect us? Well, we will get these ketones, DKA, ketosis, ketones. What are ketones? Ketones are compounds within the blood that help break up these other types of sugars so that we can breathe them out. How do we breathe them out? We break down the ketone bodies into acetone. That sweet smelling breath that people with really high blood sugar have happens because of ketosis. We are breaking down ketones and breathing out that sweet smelling acetone. That's what's going on. In fact, people in a successful keto diet will have slightly sweet smelling breath. It's kind of a side effect of that. The cells starve. Glucagon is released to promote the breakdown of triglycerides and initiate gluconeogenesis to produce glucose. All this is happening from the pancreas around those fatty deposits in the liver and other organs. This will increase the blood glucose levels. They'll accumulate in the bloodstream and are metabolized into strong organic acids, ketones, that further break down into acetone. That's what causes that fruity breath. We also will note that our breathing will get deeper and more rapid because we're trying to offload these ketones into the environment through the exocrine glands of our breathing. So that's why we call these Kussmaul respirations. They're deeper, they're faster, and they might have a sweet smelling odor. Although I'm not about to reach my face into a patient's mouth and take a whiff of their breath to prove it. I'll take their word for it. All right. So as the glucose enters the kidneys, it takes a lot of water to pull that glucose out and pee it out, because glucose is a bigger electrolyte, or it's a bigger molecule than a lot of the electrolytes which we're trying to flush out of the system. So it's going to take a lot more water to flush it out. This is why we can cause a lot of dehydration. And all that water is going to pull with it a bunch of the other electrolytes. So again, we're making ourselves a lot more unhealthy by having these high elevated sugar levels. It's not good for you. Years ago, when I first started, I guess I was going through my paramedic rotations, and I did a stop at the Tucson Fire Department Station 8. It was, which is one of the busier stations. And let me tell you, in that 24-hour shift, I did not sleep one bit, so I did not really enjoy that shift. But what I did enjoy about that shift was when we were having dinner, there was a probie at the station, and the probie made the mistake of saying that he bet he could eat. Someone brought us some Krispy Kreme donuts, and he said that he bet he could eat a whole dozen Krispy Kreme donuts. And if you're a probie in a fire station, and you say something like that, you better believe you're going to have to do it. So guess what? He sat down and he ate an entire dozen. I got to hand it to the guy. He ate a dozen Krispy Kreme donuts. Let me tell you, if you're thinking about eating a dozen of those guys, the first 3 or 4 look pretty good. Look like they're pretty enjoyable. I could eat probably 3 donuts before I'd get sick of them. It's that last 9 that really looks painful. And let me tell you, those last 3 or 4, it did not look fun. It wasn't fun for anybody. We all wanted him to stop, but he persisted and he ate all 12 of them. That night, he ended up waking up at like midnight and just ran into the kitchen and like just turned on the faucet full strength and just started drinking from the faucet for like a minute straight, because he was very dehydrated, because his body was getting rid of these excess sugar levels in his system. He does not have diabetes. He was a healthy young guy, but still his cells got all the sugar they could need, and there was still all that sugar left over, all of those carbohydrates. Don't eat a dozen Krispy Kreme donuts, in case you guys were thinking about it. All right, HHNS, the more complex and rarer of these two, but definitely the more dangerous. More often found in women, more common than DKA. so I guess it's not a little more rare. It's more common in DK. Elderly patients in nursing homes with pre-existing diseases, especially with an infection, poor fluid intake, increased urine output, or dementia are at the highest risk. Pretty high mortality rate, 10 and 20%. Again, a small percentage of them have no history of diabetes prior to this. Associated with severely elevated blood glucose, over 600, all the way up to maybe even 1200. That's the highest blood glucose level I've ever seen was in the 900s. But most of our sensors don't even count above 600. This was like a special hospital sensor. It was in the 900s. It's a lot of sugar. This will cause very excessive diuresis. It's going to essentially have the same thing. But here's the difference. We call this non-ketotic, meaning that there's still some insulin floating around in the system. This is why this is mostly affecting type 2 diabetics. But it is enough insulin in the system that the cells are able to enter in, and they're not being formed into ketone bodies to be broken down into acetones. So we're not going to have that sweet, fruity breath because we're not breaking down those sugars, those triglycerides, into ketones. Patient does not develop ketoacidosis, due to small circulating amount of insulin. A lot of the same effects as this. How do we treat either one of these? Well, if it's low sugar, we can administer D50. If the sugar level is high, the only thing we can give them is fluid boluses. And we're not giving them a fluid bolus in order to dilute the sugar because that's pretty much impossible. Okay, the sugar is not really going to be diluted by a liter of saline or even 2 liters of saline. The reason we're giving this fluid is because of the dehydration issue faced by this incredibly high blood sugar level. All of that diuresis through the kidneys is going to be extremely damaging and needs to be managed with fluid. Thyroid emergencies, hyperthyroid, thyrotoxicosis, and finally thyroid storm. This is kind of like in ascending order of danger. So again, hyperthyroid would be an overactive thyroid. This will usually cause an excess in the intake of sugar into the cells. So we're going to actually be increasing metabolism. People with hyperthyroid will typically be skinnier. This is also more likely to cause the AFib. A lot of AFib patients you guys see, think about it, they're very slender. They're usually not like big overweight patients, although that can happen. Most of them are pretty skinny. This is usually because it goes hand in hand with hyperthyroidism. This is called a goiter. This is obviously going to be a true medical emergency. What's swelling up in here? Their thyroid gland. Remember, that's where it sits, right underneath the Adam's apple. Their eyes might also swell out. This is called exophthalmos. Their temperature is going to be higher. Think about it. Your metabolism is higher, meaning you're creating more ATP more frequently. ATP breaks up and it causes what? Heat. The more hot our bodies run, the quicker we're burning calories, all right? Internal body temperature is directly related to metabolism. Metabolism is not necessarily something that you can influence, by the way. You can increase metabolism by increasing your physical activity. But as far as like if you work out every day or to make your metabolism or to increase your metabolism, that's not really how it works. Our metabolism is kind of at a set rate depending on how our body likes to maintain homeostasis. And it will take years and years of consistent diet and exercise changes to slightly alter your metabolism. However, our metabolism is changed very rapidly through activities and diet. So while we can improve our metabolism, it's not necessarily a quick process. A lot of that is just genetically ingrained within us. Some people are predisposed to lose weight and some people are predisposed to store weight. And both are efficient, by the way. In fact, realistically, it would be better for us to store all that excess fat and then use it up later when we can't eat. That's the whole purpose of why our bodies store glycogen, is because for a long period of human history, we didn't really know when our next meal was going to come. Or I shouldn't say human history, I should say mammalian history. We didn't know where our next meal was going to come from. There are crocodiles. I don't know if they're alligators or crocodiles. I'm pretty sure they're crocodiles that live in the Saharan plains. not, maybe that's not the Saharan, but like they'll live in those ponds that form, and they are so big. They're huge creatures, but they only eat once a year. They'll literally just eat like one water buffalo a year, and then they'll basically go into this hibernative state where they don't eat at all. Bears will do the same thing. They'll build up these huge fat deposits, and then they'll go to sleep for like a couple months at a time, and they don't need to eat. Now, they're not real feeling great when they wake up from that, and they've lost a ton of weight because their body's broken down all that fat. So realistically, fat is good for us, right? We should all be fatter. We should all have a layer of blubber on us. The reason we don't is because of aesthetic changes that happen over time, which, by the way, that also is a cyclical process. All of fashion and sex appeal comes and goes. It used to be that bigger people were considered sexier when it was harder to get fed, right? Because that was a sign of health. Now that, you know, you can go to McDonald's and for $1.50, I can get a 300-calorie cheeseburger. It's very easy to become fat. So what's healthy is someone who takes care of themselves. Myxedema, caused by deficiency in thyroid hormone, associated with thyroid inflammation. A couple different causes of it. It's an autoimmune disorder with ongoing inflammation of the thyroid. Again, now we're going to see maybe a little lower temperature, hypothermia, mental obtundation, facial edema, JVD, weight gain. So again, now that our metabolism is decreasing, hypothyroidism, we're going to gain weight and our body temperature is going to actually drop. These two things just go hand in hand. Adrenal emergencies. Remember that the adrenal glands are part of the endocrine system. So there's two things here, Cushing's and Addison syndrome. Cushing's syndrome, the same guy that came up with Cushing's triad, by the way, that was a really good doctor, results from an overactivity of the adrenal glands causing overproduction in corticosteroid hormones, usually the result of an adrenal tumor or the overmedication of steroid drugs. In fact, a very interesting thing is that this might remind you of some of the side effects to steroid use. I remember when I was in not elementary school, but like middle school and high school, they did a bunch of talks about not using anabolic steroids because they'll turn men into women and women into men. This is kind of partially true. Obviously, those are slightly different chemical compounds than the ones released by our adrenal cortices, but we're going to see a lot of the same things. That buffalo hump, the fat deposits in your upper back, which is the supraclavicular fat pads, increased body and facial hair, weight gain, and high blood pressure. Also going to put you at a higher risk for diabetes. Next is Addison's disease, which is much more rare, but much more deadly. Any disease that destroys the adrenal cortices is what causes it. Deficiency in cortisol and aldosterone. This is going to cause big problems with your blood pressure regulation. Progressive weakness, weight loss, hyperpigmentation of the skin, hypotension, and electrolyte imbalances. Again, our body's not doing as good of a job regulating blood pressure, which is very important. We're also going to see this hyperpigmentation of the hands, right? This is the melanin. Sometimes this is a condition known as melasma. A lot of people experience this. Women will experience it usually when they get pregnant. There will be a darkening of their skin pigmentation in the nipples and sometimes in the face. It happens to a lot of women that they will develop this condition called melasma, where they will start to form kind of like a darkening of their skin right on their upper lip, is in particular one of the places it's most commonly affected, which kind of gives them the appearance slightly of having like almost like a 5 o'clock shadow mustache. Obviously, women don't want this now, so that's something women that try to treat, but that's a similar condition with hyperpigmentation of the melanin. By the way, if you're very white and you have a friend who has very dark skin, like a very black friend, you have the same amount of melanin. His melanin is just more active. Melanin is just there to help us absorb vitamin D, but limit the amount of vitamin D. However, vitamin D is extremely important, and we are one of the few mammals that does not synthesize their own vitamin D. Have you guys ever noticed that most mammals are completely covered in hair and we are not? Why is that? Because most mammals can synthesize vitamin D through their diets and through the environment. They don't need the sunlight. This is why they can hibernate for 3 months at a time. You try laying in your bed for 3 months and tell me how healthy you are. You're not going to be very healthy. In fact, some people live in very high northern latitudes where the sun does not really show for long periods of time, or it only will show for an hour or two a day. They're almost exclusively lower contents of vitamin D in their system. By the way, anyone suffering from vitamin D deficiency is at a much higher risk of contracting diseases like COVID. How do you get and make sure you're getting enough vitamin D if you're not getting outside? Well, it takes a lot. You need to eat about 6 pounds of cheese every single day to get enough vitamin D. Or alternatively, you could try some cod liver oil. Like a half teaspoon of cod liver oil will give you all the vitamin D you need as well. So you could eat 6 pounds of cheese, or you could take a couple like cod liver or fish oil pills. I know which one tastes better, but 6 pounds of cheese seems kind of unreasonable. I normally average about 3 to 4 pounds of cheese a day. And I think that's much more reasonable. So Addison's disease is going to have a slower onset, but can develop an acute episode called Addisonian crisis after stress, infection, alcohol intoxication, or something that's causing a huge release of epinephrine, aka an adrenal response. So like a heart attack, low temperature, can be exacerbated by any sort of adrenergic response, aka sympathetic nervous system response. Again, all the treatment for this is going to be maintenance, right? Make sure that their ABCs are good, SpO2 between 94 and 95%, IV to keep their blood pressure over 90, get a good blood sugar.